Yeah, we have a handful of questions from a few of our shareholders, which is great. So a couple from Mr. Michael Dobrojevic. So apologies, Michael, if you're online and I've mispronounced that. With the most recent capital raise, is there any progress on covering the shortfall? So I can probably field that to start with. Yeah, the shortfall was priced at 1.7 cents, and given where our share price is currently trading at 1.5 cents, it is just not feasible at the moment to be placing that at a premium to our share price. We do have until early July to get that done. So we will leave it open for a little bit, and we'll make a call on where we think that's heading in the next few weeks and inform shareholders. We certainly did have some good progress prior to our share price falling below the offer price, and those people are still potentially keen, and we're re-engaging with them regularly, but it really is a factor of our share price at the moment. Anything else to add?
No.
Another question from Mr. Dobrojevic. This is again around capital raising. Should future capital raises be targeted only to sophisticated investors who are potentially more likely to support the company long term? This is in Michael's wording here. It seems that the current shareholder base do not have alignment with the positive path for the company. I won't comment on that. That is everyone else's. That's their prerogative. But we decided this time around, instead of doing a placement to sophisticated and high net worth investors, that we would do an entitlement offer to give everyone a chance on the register to participate. And we're very grateful for, we raised over $400,000 in this climate with where our share price was at. We're very grateful for that and really appreciate that support. Whilst we also thought we would have a shortfall of $1.5 to $2 million, that we were looking at sophisticated investors and high net worths. So we were kind of trying to appease everyone. Unfortunately, given market conditions and where we're at, it didn't quite come to fruition, but we certainly don't regret going down that path. Another question from Mr. Dobrojevic. In the most recent annual report, nearly half of the shareholders have holdings less than a marketable parcel. Are there any plans to buy these shares back? So just a marketable parcel is less than $500 worth of shares, just to spell that out. Two answers to that. One, it is quite you've got to pay for the shares. It's around 40 million shares at our current share price, or maybe closer to 50 at the moment. If our share price was 5 cents, for example, it'd be a far less amount of shares. So a lot of these shareholders have bought very small parcels of shares. And for us and the business we're in, I would really, as much as sometimes it's a pain handling 8,500 shareholders and you have to mail out AGM notices and the like, a lot of these investors have invested for a reason that, one, they want to see cancer detected earlier, and it's very much an emotional journey for them. So I don't believe that going down the route of buying back those shares, even though we're entitled to, is something that we're considering at the moment. I don't have anything else to add on those. So thanks, Michael, for those questions. A few questions from Mr. Anestis Lazaridis.
So do we want to close voting before we keep going?
We can. Yeah, it's been a couple of minutes.
Yeah, it's been a couple of minutes. So we can, at this point in time, we'll declare voting closed, and we'll continue with the Q&A session then.
Yep. I'll direct these through you, Bob, and anyone else, feel free to jump in. So sort of two-parter here. What strategies are being or going to be employed to recruit patients? And you coincided with patient numbers. How was and is the sample size determined for the phase 1 and phase 2 study?
Yeah, so I'll answer those in reverse order. Going into the phase 1 study, we really didn't have to worry too much about the quantum, because that's pretty much dictated by the regulators. When you're doing an early phase study like that, they pretty much restrict how many patients you can get access to, and then they want to see the data before they're going to give you permission to go more. So we knew going into it that the target of somewhere between 10 and 15 was likely to be where we would start. We designed that study with being able to go up to 30 because we didn't know what kind of data we would get. But the idea was that we'd start with a simple phase 1 study of somewhere in the order of 10 to 15 patients. As you go into the next phase of things, Now you start to worry about the statistical relevance of what you're looking at. And so the number of patients that we will plan to recruit into the phase 2 study will be driven by the biostatisticians looking at, well, what are the endpoints we're trying to achieve? And how many patients do you have to have in order to be able to be confident in your data supporting that? So we're just in the process of doing that now. Part of the run up to the IND filing is, in fact, getting the biostatisticians involved with the clinical investigators to identify the endpoint or endpoints, so we can then back calculate how many patients do we think that we're going to need to be able to get to that proof of evidence. And one of the things that's important there is, we were discussing this the other day, is as you go through this process of going from phase 1 to phase 2 to phase 3, the ability for the sponsor, i.e. the company, to be involved as the study is going on gets less and less. So what that means is that by the time we're doing a phase 3 study, we have to have defined the exact protocol, exactly what's going to be done for every patient, and what our endpoints are, because we can't really change it in the middle of the study. So you're committed to something, you're actually blinded to the data until the end. And so if you don't get your study design right, you've tested a whole bunch of patients, and at the end you find out, did you achieve what you wanted to achieve or not? So the reason that we're doing a phase 2 instead of going all the way to a phase 3 is we still have some flexibility in the phase 2 to try to figure out exactly what those endpoints we want are, so that when we do go spend the money on the larger study, we're pretty darn sure that we're going to get the outcome that we wanted to, because we really need to make sure that we've locked everything down. So the trick right now is, in the next couple of months, to work with our investigators and the biostatisticians to say, if these are the endpoints that we want to try to get to in phase 2, so that we know what we're planning for phase 3, how many patients do we think we need to do? And so we'll be in the process of doing that. And that will then drive, for example, how many study sites do we need, and how quickly do we think that we can recruit patients into that study? One of the things I mentioned in my chairman's remarks was, there are a few things working in our favor now for phase 2 compared to phase 1. One is we can have a lot more study sites. We're planning to have, probably more than 10 study sites, whereas in phase 1, we only had 4 here in Australia. In Australia, we have 25 million people, of which HER2 breast cancer is only 20% of breast cancer. So our patient population was immediately very restricted. In the United States, we're going to have 350 million people, but with the same incidence of breast cancer. So the numbers are just bigger. And so we know, for example, that hospitals in the United States have typically in the order of 5 to 10 times the number of patients with breast cancer that you might see at a hospital here. So the trick will now be for us, again, same thing, over the next 6 months or 3 months while we're working towards our IND, is do the analysis of how many sites do we need based on the statistics of what we have to achieve, and what are the sites telling us in terms of the number of breast cancer patients that they see on a regular basis that we could potentially enroll. And then again, one last thing working in our favor is in the phase 1 study, because we really wanted to know whether or not we see cancer in lymph nodes. It wouldn't have done us any good to recruit patients that were node negative. We'd find out whether our nanoparticles get into the lymph nodes, but we wouldn't know whether or not we were detecting cancer, because those patients had, by definition, a priori, didn't have nodal disease. So we restricted our phase 1 study to only be patients that were expected to be node positive. Node negative patients are more than half of breast cancer patients. So we automatically started that study restricting half of the patient population. So when we go into the phase 2 study now, in order to prove our case that we can differentiate node positive from node negative, we're going to have to recruit all breast cancer patients to see if we get the answer. So the number of patients available to us by population, the number of patients available to us by number of study sites, and the number of patients available to us by eligibility will all be increasing, which is why we think we'll be able to get through the phase 2 study in a reasonable period of time. But exactly how much time will depend on how many patients and how many sites we have. And we're just starting to accumulate that data now. So I can't quite get an answer today on how long that's going to take. But we'll be working on that as we move towards the IND filing.
And we'll give some updates and indications.
Absolutely. As it starts to unfold and we get clarity and we have that trajectory planned out, we'll be able to share that.
Yeah, I guess sharing something now would be a guess, and we know what happens in the minds of shareholders when we put out information that's not accurate. So, are there plans for collaboration with other research groups or institutions in the future? Maybe just touch on where our MassGen and
So while we're very focused, the majority of our effort is focused on this HER2 breast cancer, getting it through the clinical phases. I'd say there's two other aspects to our research programs. One is our immediate pipeline of other potential cancer imaging targets like prostate cancer and ovarian cancer. So we have some collaborations right now in prostate cancer. They're relatively small while we're doing early stage work, but those collaborations are likely to grow as we start to focus on the clinical utility for prostate cancer. The same thing for ovarian cancer. We'll have to find those researchers that are interested to work with us on the clinical development of ovarian cancer. Behind that, and we have, a relatively small project working with the University of Sydney in the brain cancer that we have. Behind that is some fundamental R&D work that goes on. We're constantly looking at other utility for our particles. And so we have collaborations looking at everything from how our particles might be used from a therapeutic perspective to collaborations on what other targeting ligands or moieties we might use to target different types of cancer. So they tend to be relatively low level, from an expenditure perspective, because they're early stage work in that, but we're always looking at additional collaborations that can support ultimately getting us into the clinic for our products. Because from our perspective, we're not interested in being just a fundamental R&D organization. Our goal is really to drive getting products into the clinic so that they can ultimately be approved by the regulators for actual use in human testing.
Yeah, any follow-ups?
No.
Got some questions through from Dr. David Butterfant, another holder. This one's back to the phase 1. What has been the rationale behind not incentivizing patients as it is a non-invasive procedure?
Yeah, so two things there. One is incentive for people to participate in phase 1 is usually associated with what's known as a healthy volunteer study. That is, we're simply trying to identify for a drug whether or not, if this drug is administered to someone who doesn't have a disease, is a healthy individual, whether there's any side effects, toxicity problems, or anything. And so you're asking people who are otherwise perfectly healthy to be given a dose of a drug that they've never seen before. And so it's very common in that scenario to provide a financial incentive to participate in those studies. It's not seen as being unethical because you're asking somebody who would otherwise not need any kind of treatment to be given something. When you move away from a healthy volunteer study to the kind of study we did, where we're actually looking at actual patients, in our case, HER2 positive breast cancer patients. The ethics associated with incentivizing people to participate starts to get a little bit fuzzier, right? Because now these patients are considered, or these subjects for the study are considered at risk or vulnerable, right? If you incentivize them to participate in your study, are you disproportionately weighing a financial benefit to them compared to just the standard of care? These are people who have been diagnosed with a disease, and you want to make sure that you're not interfering with their patient treatment and the standard of care. And there's always a concern that if you try to incentivize them financially, that they will make a decision that is more based on the finances than it is on their health care. And so it's pretty much seen as being the ethical boundary that when you're recruiting patients into a study that are actual patients with the known disease, that you don't add a significant financial incentive for them to do that. Now, you can add compensation, which we do. If someone needs to stay in a hotel, or if they don't live proximal to where the study site is, you can pay for transportation. You can compensate them if they miss work. You can compensate them at normal labor rates for them so that they're not out of pocket, having participated in your study and having lost wages. So those things can be done, and that's all considered fair and ethical, and we include that in our study. but it is typically not seen as being ethical to try to financially incentivize somebody to make a decision to do something that may or may not be in their best standard of care interest.
Thanks, Bob. A few other questions. Are there plans, just sort of a two-parter, are there plans to publish the results of the phase 1 study in a scientific journal, and potentially when could that happen? And what are the predefined benchmarks or standards against which the results will be compared to?
Okay, so I'm going to reverse those two. So in our study, the standard of care or the benchmark is the clinical evaluation that is given to the patient before we do our study, and the pathology that is assessed of the actual tissue that's excised from the patient. So in our study, a physician, the doctor assesses the patient. They have been identified by doing a biopsy of the primary tumor that they're HER2 positive. And now the evaluation is typically by ultrasound to look and see whether or not there's the nodes appear to be involved. And then depending on how the ultrasound looks, they may then do a biopsy of one or more nodes, and they take that tissue and they look in the petri dish and they look for the pathology to see if there's cancer cells there. So the normal clinical evaluation is doctor's evaluation and an ultrasound. And so our first comparison is, what did the doctor say? Is this patient node positive or node negative by clinical evaluation? And then what do we say with our imaging results, and how does that compare to what the actual biopsied sample looks like? So we have a very good way to compare our results to standard of care and the clinical evaluation. And so then the first part of that question was
Publishing results.
Publishing results. So right now we're in the process of starting to wind down the phase 1 study. Well, then, you guys are very familiar with this. You then, it takes a while for all the data to be compiled. You got to make sure that all the data in the database is locked down, et cetera. But once that data are there, I fully expect that our team, in concert with the study investigators, will publish. I mean, one of the reasons that the investigators like to participate in the study, they're typically academics, they're at hospitals and that. And so they like to, for them, it's a benefit to participate in the study, not only to help their patients, but they get the publication out of it as well. So we would fully expect to do that. I would say, it's probably going to be not less than 6 months, though. It takes a long time for the database to get locked down and all the data to be reviewed. And then if you're going to submit into a scientific journal, they're peer-reviewed journals, and you go through multiple iterations of where this other scientists read your results and ask questions and ask you to comment on things. So it's not something that's going to happen quickly, which is why we felt it was important to at least publish the poster that we presented at the San Antonio Breast Cancer Conference, because at least then our shareholders get to see some portion of the data. But we'll plan to do a publication, a more thorough publication, but it does take time to get through the scientific rigor.
Like anything in biotech, it takes time. Just another question from Dr. Butterfant. What limitations and constants and constraints in terms of resources, funding, or technology that may affect the scope of future studies like the phase 2?
So by having moved to MRI for our detection platform, we actually reduced that burden. Had we continued with development of the magnetic relaxometry technology, we would have had both a financial and technical constraint of having to make it instruments that would be put in the hospitals for the testing. By moving to MRI, we're taking advantage of the existing infrastructure. Almost every hospital that we would be interested, or clinic that we would be interested in working with, will have a commercially available clinical MRI machine. So that actually reduces the financial and technical constraint. There is nothing, I want to be careful here, there's nothing special about, there's something special about our nanoparticles as an imaging agent, but there's nothing special about the imaging equipment itself. We don't have to have a special version of software running on these MRI machines. We don't have to have a special coil to do the pulsing of that, right? So all of the hospitals that we're going to be working with, and it can come from any vendor, GE, Siemens, United Imaging, Philips, all the major vendors of MRI machines, their machines will work perfectly well with our imaging agent. So the technical constraint is a lot less by having moved to the MRI detection. The financial constraint will be largely driven by how many patients, how many clinical sites to appropriately fund the study.
Yeah, one more question. What are the long-term implications, I guess, of our technology for future research or clinical applications? And what are those potential applications, I guess, beyond the phase 1 study?
Yeah.
Yeah.
So I think they're here. The thing that's right in front of our face is that we can now start to do what's known as molecular imaging by the use of our particles. So instead of administering a contrast agent that just helps make the images brighter, gives an improvement in signal to noise, our particles actually generate a contrast that's associated with the fact that we know that the cancer is there because our particles are attaching to the tumor cells. That changes the way the radiologists start to think about, and the physicians start to think about how they could use imaging to make decisions about A, diagnosis, and B, potential treatment. One example in our phase 1 study that we originally started the idea that all we want to do, let's start simple. Can we simply, yes or no, determine whether there are cancer cells in that patient's lymph node? By moving and starting to get images by MRI, what we're noticing is that the initial assessment today by a clinician is, as I said, ultrasound. They're going to take a patient, they're going to do an ultrasound and see if they see nodes that are abnormal in size and shape. If they're abnormal in size and shape, it means that it's probably not a healthy normal lymph node, that node is involved with tumor cells that's caused the change in size and shape. So it's just an ultrasound image looking at morphology or anatomical changes in the lymph nodes. When they look, and typically an ultrasound it can only look at a couple of nodes. They'll look at the nodes most proximal to where the tumor was. What we're finding with the use of our imaging agent is not only can I look at size and shape by MRI, I can look at abnormality of size and shape of the nodes, but I now see whether our particles are generating contrast related to the presence of the cancer cells. So I add one more piece of, let's say, factual data to the radiologist's interpretation. I've got a node that looks abnormal in size and shape, and I see the contrast associated with the particles. Or I see a node that maybe I didn't think was abnormal in size and shape, but I see the particles there. So what I have otherwise maybe thought that node was normal, but in fact, it turns out that there's cancer cells there. But another big benefit that we're seeing is that with MRI, we can actually image a larger number of nodes. And the number of nodes that have cancer cells in it can affect the way the doctor thinks about the course of treatment. It's not just whether or not maybe that patient has one node that's metastatic, but if I've got 5 nodes and I see it's disseminated deeply down into the axillary region, I might think about whether or not I don't want to treat only by neoadjuvant therapy, but maybe I want to do surgical because I want to get rid of as much of that as possible. So what we're already seeing with the use of our technology is we might be able to start to change some aspects of clinical practice because we're giving them more information than today they might have. The next big thing to go after that is, we've said this all along, if we start to demonstrate that we have particles there and they're associated with cancer cells, we know we have the possibility then of that using those nanoparticles as a drug delivery mechanism. If they're there and I'm detecting them, how can I then potentially include a therapeutic payload and start to treat the tumor? So our long-term vision of the evolution of our nanoparticle technology is we affect clinical practice to give the radiologists and the doctors more information to make better decisions about how to treat a patient. But ultimately, we might also play a role in actually treating the patient with our particles.
I confirm no further questions.
No further questions? With that, last chance in the room? Great. Thank you. I want to thank everyone for attending the meeting. Look forward to the next 12 months and keeping everyone apprised.
Thank you.